So thank you all for attending my talk on lifestyle risk communication by nurses in primary care and integrative review. This forms part of, or at least the beginning of, a PhD through the University of Wollongong under the supervision of Professor Liz Halcombe, Dr. Jane Desborough and Ms Susan McGuinness. My interests in this area are related to my own experiences as a practice nurse. So internationally, the primary care settings are contending with an increased patient demand as well, or secondary to chronic disease, as well as a decreasing medical workforce. GPNs comprise of the largest non-physician workforce in primary care. Given their employment within the community and prolonged engagement with patients, they play a pivotal role in community-based healthcare delivery. In recent years, health systems such as New Zealand, United Kingdom and Australia have implemented policies that have supported increased and enhanced roles for GPNs to deliver or assist in the meeting the growing demands in primary care. In the Australian context, 53.7% of patients who present to general practice have at least one lifestyle risk factor. It is estimated that 67.2% of GPN patient encounters consist of disease-specific health education. Despite the allure of the GPN role in lifestyle risk reduction, it has been suggested that current primary care service delivery aimed at achieving such changes is inadequate. Many factors influence the GPN role, such as workplace organisation, funding, as well as patient, personal and professional factors. Several studies also identify the GPN role as being largely underutilised, particularly in terms of nurses being supported to work to their full scope of practice. Within this context, the aim of this literature review is to examine the experiences and perspectives of lifestyle risk communication by primary care nurses so that effective service delivery and management of chronic disease may be undertaken. So an integrative review was chosen due to the mixed nature of research available. An initial search of Scopus, Medline, CINAHL, Johanna Briggs Institute and Cochrane was conducted for peer-reviewed papers published in the English language. Hand searching of reference lists also occurred. Electronic database search sought primary research, which focused on primary care nurses' perceptions, attitudes, experiences and/or perceptions of perspectives of lifestyle risk communication with adults. And due to the evolving nature of general practice, nursing papers from January 2006 to October 2016 were searched. From the 670 papers, and following removal and review of articles, 15 of those papers remained. So from these 15 papers, quality appraisal and data abstraction and synthesis was undertaken. 60% of those 15 were qualitative in nature, 12 were from Europe and 3 from Australia. So more of the recent European papers relate to communication strategies, and 3 of those relate to motivational interviewing usage. Of the 3 Australian papers highlighted in red up there, 2 of those discuss nutrition care. Thematic analysis, the process of representing patterns within the data, was informed by Braun and Clark, and 4 themes were found. The first one, GPN views of the nurse-patient relationship, was divided into 2 sub-themes: person-centred care and engagement and ownership. Nurses sought rapport and individualisation of communication and felt that patient-related factors had an impact on this relationship. Person-centred care approach refers to the nurse's relationship with a person based on trust and respect individual rights and personal preferences. There was evidence that nurses wanted to undertake a person-centred and directive approach to their communication with patients. Aspects of person-centred care were found where communication was individually tailored, following consideration of content, context and delivery, language, culture, and addressing the patient's knowledge deficits. When trust between the nurse and the patient was present, individualisation of care was found to occur through attention to a patient's social supports, resources, and environmental constraints, as well as showing sensitivity and empathy. The use of person-centred care, however, was enacted inconsistently, with potential to revert to an educational or shock tactics approach. Engagement and ownership. Nurses were often described as being frustrated by perceived patient unwillingness to make behaviour change, poor self-discipline and limited insight regarding the need to make lifestyle changes. Patient empowerment was seen as a key for motivation and ownership of their health care. The absence of lifestyle risk communication as well as the method employed was found to have an impact on engagement. Examples were descriptions of nurses who were uncomfortable or concerned with addressing issues such as weight and smoking, or who did not strive to make patients equals in the dialogue, or who used shock tactics. Motivational interviewing, a person-centred and directive method of communication, requires training and, while professionally demanding, was seen as satisfying, stimulating, useful and an effective method in assisting lifestyle change. Patience, flexibility and mutual interest in the method were seen as key factors to the technique's success. Motivational interviewing was found to assist in providing communication structure, a patient's self-determined strategies for change, but also maintaining person-centred care. Despite positive regard expressed by nurses trained using the technique, they were reported to overestimate self-rated performance compared with scoring. Motivational interviewing use was therefore deemed to require ongoing support, training and feedback to maintain proficiency. Barriers to practice. Preventative and health promotion tasks were reportedly viewed positively by nurses who aspired to increase their practice of this. However, personal, professional and organisational factors created barriers to role expansion. Personal factors. Impeding lifestyle risk communication centred on the nurse's interest, confidence and struggles with the technique. Nurses were identified as lacking confidence resulting from perceived knowledge deficits and introducing potentially emotionally charged subjects such as weight management. The motivation of nurses was required in learning and adhering to new techniques such as motivational interviewing. Difficulties with nurses' motivation were also reported where repeated lifestyle advice was delivered with uncertain success, potentially impacting on empathy for the patient. Some papers described how nurses struggled with internal conflict where they were reluctant to risk established rapport through introducing a potentially sensitive topic, or when patients' perceptions of the nurse's own lifestyle risk factors were an impediment to being receptive to communication. Professional factors. Improving knowledge and availability of training regarding communication content and delivery featured prominently. The delivery technique involving a person-centred approach rather than an advising or educating model was an important factor to supporting behaviour change. Training and experience was seen to improve opportunistic lifestyle risk encounters, personal resourcefulness and self-perceived effectiveness. However, many nurses felt they did not have sufficient skills or training in lifestyle counselling. Barriers to achieving knowledge and skill improvement were found to exist around time, funding and the availability of training opportunities. Organisational constraints included time, policy and workplace priorities. Most nurses identified their busy schedule as a barrier for lifestyle discussions. Limited time was frequently identified in terms of time allocation, opportunity, volume to be discussed, rapport established, and the progressive delivery of information over time. Government policy was seen to support funding towards high-risk groups due to inadequate resources and perceived priorities. However, disadvantaged groups struggled to access primary care services. As a result, opportunistic encounters and meeting the needs of disadvantaged populations represented potential development opportunities for health promotion and prevention activities. Doctor and workplace priorities supporting lifestyle risk communication interventions were seen as both enablers and barriers. One barrier was a reluctance to adopt and the ongoing use of motivational interviewing. As primary care services have not historically offered lifestyle risk advice, it is possible that some old habits prevail. Despite current funding arrangements, organisational resourcing constraints were also seen to exist around patient educational materials and appropriate consultation space. Lastly, role parameters. While GPNs were viewed as approachable and in prime position to provide lifestyle risk advice, this was mainly undertaken opportunistically within chronic disease management consultations, rather than having clearly defined dialogue content, roles and responsibilities within the multidisciplinary team. This was true of interventions related to weight management between the GP and nurses and nutrition care between dietitians and nurses. The inherent complexity and multidisciplinary approach to lifestyle risk communication necessitated collaboration between providers. So limitations, younger people were excluded from the study given the complexities and differences in lifestyle risk factor modification in this group. And additionally, the review literature did not describe the use of non-verbal communication in GP and patient lifestyle risk encounters. Despite this, the review found that procedural enablers are required. Issues of time necessary for lifestyle risk communication are linked to workplace priorities and government funding arrangements. Time allocation was found to directly impact on the presence, type, quality and duration of lifestyle risk communication. Lifestyle risk communication requires time and timing to ensure readiness for behaviour change. This review revealed uncertainty amongst GPNs regarding their effectiveness conducting lifestyle risk behaviour change. The perceived benefits of using MI and its adaptations did not necessarily transpire to ongoing technique adherence. And nurses also reported a lack of confidence and motivation as contributing to this. GPN concerns are supported by literature reporting the necessity of ongoing training and workplace support in behaviour change counselling techniques such as motivational interviewing as required to maintain improved confidence and competence. Issues of role clarity and expansion identified in the review resonate with other research. Role ambiguity has been influenced by historical patterns of care and hierarchy within primary care. However, clearly delineated role boundaries provide a basis for effective collaboration and optimisation of GPN roles. An expanded use of nurses to address lifestyle risk factors could be effective in meeting current and future chronic disease demands, and such initiatives are in line with government strategies to prevent chronic disease. However, it has been argued that current funding models influence GPN clinical practice, and in the current primary care environment where chronic disease demands are increasing, there is both opportunity and need for organisational and government support of GPN activities to be bolstered. Alternative funding arrangements supporting ongoing GPN delivery of lifestyle risk communication could fill the needs identified in this review of those at risk of lifestyle disease and disadvantaged groups. So, in order to deliver optimal chronic disease management services, GPN views regarding lifestyle risk communication are required to inform policy and practice. GPNs require procedural enablers such as role clarity, organisational government support to undertake ongoing and effective lifestyle risk communication. GPN use of behaviour change counselling techniques such as motivational interviewing are effective for lifestyle risk communication and assist in the maintenance of therapeutic relationships, but also require ongoing and effective training and support. Ta-da.